Everyone, let us start today's very important session. So welcome guys to this very important session, PYQs. Today it is ENT, and we all know that ENT carries a lot of weightage in exams. So we have close to like over 40 questions in all. We'll try to do it as fast as possible. I don't want to spend too much of your time because you're closer to the exams. So we'll start with NEET PG questions of 2023. And this is your first question. So it's an image based question. This was asked last year, 23. And it says, you can see that arrow marked here. There's an arrow this side. And the question says, identify the marked structure. Is it tubal tonsil? Is it fossa of Rosenmuller? Is it torus tubaris or station tube opening? It's a very simple question, I think, and most of you must be able to answer this question without any problem. This area, which is actually behind the station tube, is the fossa of Rosenmuller. So B is the correct answer in this particular case, fossa of Rosenmuller behind the eustachian tube. So look at this image here. Now in this particular image, you should be ideally be able to identify four things. Which are these four things? One, of course, is this arrow marked area, which is the question, is fossa of Rosenmuller. And which are the other three things that you must be able to identify? One is this. This is the station tube opening. So one of the choices was station tube. And behind the tube, this area, this bulge area behind the tube, this area, and this area is called the fossa of Rosenmuller. So we have station tube, we have fossa of Rosenmuller, and we have torus tubaris, and this red thing, this whole thing is the adenoid. Adenoid, a type of tonsil. So if you can identify these four things in the image of nasopharynx, this is a image of nasopharynx. Right. So this is the first question. The answer is fossa of Rosenmuller. Next, one second. One second, guys. Let me switch on. So this is the second question. A patient presented with change of voice. He was diagnosed with cancer and underwent an intervention. Following which surgeries is the following intervention? So it says a patient has change of voice. This tells you it's most probably a larynx, specifically a glottic problem. And then he says there was a cancer. So straight away the diagnosis is given. Now, this is an opening in the neck. And this opening in the neck is called permanent tracheostomy. See, tracheostomy or tracheostomy usually is not a permanent thing. It's done for few weeks, few days, few months, depending on the situation, and when the patient cannot breathe. And once the patient starts breathing normally, we remove the tube and we close the opening. but this tube that you see is a permanent opening, and permanent tracheostomy is most commonly done in total laryngectomy. So when you do total laryngectomy, then permanent tracheostomy is usually done. So you can see it's a big opening on the neck, and this tells you, and it says, so two things here. One, it tells you the patient is suffering from cancer, and that's why there is a voice change. And if for a cancer you have this permanent tracheostomy, then most likely the patient has undergone total laryngectomy surgery. Right? Because in other partial laryngectomy or vertical hemilaryngectomy or horizontal hemilaryngectomy, we don't do a permanent tracheostomy in any of these conditions. So total laryngectomy is the correct answer. Although nowadays total laryngectomy is less commonly done, because total laryngectomy has a lot of disadvantages, but that's why it is not done. But in this particular image, look at this image here, you can see a permanent tracheostomy, and through the tube you can see this a valve. There is a valve inside, and this valve is a TE valve, tracheoesophageal valve, which is put in tracheoesophageal fistula. That means the patient has tracheoesophageal fistula, a fistula has been created there, and we have put a valve inside. The idea of doing all this surgery in a patient of total laryngectomy is for what? Speech rehabilitation. So patient has undergone basically in a patient of total laryngectomy. So this is the whole information about this particular question. The patient has laryngeal carcinoma, that's why the patient has change of voice. For that the patient has to undergo total laryngectomy, and in total laryngectomy there is loss of speech, no larynx, no voice, isn't it? So we may have to do speech rehabilitation, and this is the procedure that we do. We make a tracheoesophageal fistula, and in that tracheoesophageal fistula we put a valve. Right? Now, very commonly asked question, they ask you, they'll show you these images of the valves, and they ask you the name of this valve. So when you do a tracheoesophageal fistula and put a valve inside, these are the 4 different valves that can be put inside. One is Blomsinger valve, the first one, which is the most popular valve that we use in these patients. The second valve that you see is a Provax valve. The third one is Grosjean valve button, and fourth one is a Pange voice button. So these are the 4 valves that can be used in a patient of tracheoesophageal fistula and tracheoesophageal speech. So the question was about this. Let us go to the third question from the same year. A patient has negative Rhinitis at 256 and 512 Hertz, but positive Rhinitis in 1000. So what is the AB gap? So sometimes, you know, AB gap means airborne gap. So we do, this is done in Rhinitis test. In Rhinitis we do AC checking and we do the BC. If this pen is a tuning fork, we place outside the ear to check the air conduction. We place on the mastoid bone to check the bony conduction, and we ask the patient how much is the AB gap, and depending on it what frequency the patient has negative Rhinitis, you can actually know the AB gap. So we'll come to this question answer, but look at the table that I have prepared for you. If the patient is only negative at 256, but positive at 512 and 1000, then the AB gap lies between 15 to 30 decibel. If the patient is negative at 2 frequencies, that is negative at 256 and negative at 512, but positive only at 1024, then the AB gap is between 30 to 45 decibel. And if the patient is negative in all 3 frequencies, then it is more than 45. So because in our question, the question said the patient is, this is the situation. Second one, the Rhinitis is negative at 256 and 500, and 12, but positive at 1024. So it has to be 30 to 45 decibel AB gap. So answer is B, 30 to 45 decibel AB gap. So this is straightforward. There is no concept here. It's just a factual thing. You just have to remember the fact. That's all about this. Then we go to the next question. Question number 4. Again a tracheostomy question. A tracheostomy tube is not indicated. So same year, in same paper, there are 2 questions related to tracheostomy. One was permanent tracheostomy. The first question we discussed is permanent tracheostomy. That is also related to tracheostomy in total laryngectomy patient. And this is a proper tracheostomy that is done for any other condition. So this is a cuffed tracheostomy tube. This is a cuffed tracheostomy tube. So basically, cuffed tracheostomy tube is used for 3 situations: for prevention of aspiration, because a normal uncuffed tracheostomy tube cannot prevent aspiration, and second thing is to give positive pressure ventilation. Positive pressure, respiration or ventilation, whatever you call it. So which is usually done in a CPAP machine, like people suffering from obstructive sleep apnea syndrome. In those patients you have to give positive pressure ventilation. For that also you will need a cuffed tracheostomies. So these are the 2 most important indication for a cuffed tracheostomy tube. In all other indications we can use a uncuffed tracheostomy tube. Now, in which of these condition will you come across this condition? Either there is a tracheostomy, either there is aspiration, or there is you need a positive pressure ventilation. Now, if there is a unilateral abductor palsy, in unilateral abductor palsy, the only complaint is hoarseness of voice. So this is related to a vocal cord paralysis, and for this you don't need a tracheostomy tube. If there is an upper respiratory tract stenosis, then you need a tracheostomy, but it is not necessary to use a cuff tube. You can use an uncuffed tube also, or you can use a cuff tube. In oral surgeries, again in oral surgeries, because you might have to prevent aspiration, could be a problem in oral surgeries, and that's why you might have to use a cuffed tracheostomy tube. In bilateral abductor palsy, the patient may have dyspnea, which is breathing difficulty, and plus minus voice change, hoarseness, mild voice change, but mainly it is dyspnea. Now, in oral surgeries, aspiration may or may not happen, not necessarily. So this is not always true, and you don't need a tracheostomy tube, because if you do a surgery in the oral cavity, the patient will always breathe from the nose. So out of the lot, the best answer is the 4th one. 4th one is a condition where you have to do a tracheostomy. In rest of them, tracheostomy may or may not be required. That's why in this particular case, because dyspnea is a serious situation, and so tracheostomy has to be done. So that's the correct answer in this case. Now talking about vocal cord paralysis. Now vocal cord palsy can broadly be due to recurrent nerve palsy and vagus palsy. These are 2 most common conditions that leads to vocal cord palsy. Recurrent nerve palsy is called abductor palsy. So there were 2 choices of abductor palsy in this particular question. First one said unilateral abductor palsy. The last one says bilateral abductor palsy. There are 2 choices having abductor palsy, right? Whereas vagus palsy is called adductor palsy. You have to know this. Now, both the palsies can be unilateral or bilateral. Also, vagus palsy can be unilateral or bilateral. Like I said, in unilateral abductor palsy, hoarseness is the only complaint. So you don't need no tracheostomy required. For dyspnea, you may have to do tracheostomy. So that's why this is the correct answer, bilateral abductor palsy. In this case, aspiration is plus minus, so usually no tracheostomy. But bilateral palsy, aspiration is already there, so you may have to do tracheostomy, right? So out of the 4 types of vocal cord palsy, unilateral abductor palsy, bilateral abductor palsy, unilateral adductor palsy, bilateral adductor palsy, there are 2 palsies where tracheostomy may be required: bilateral abductor palsy and bilateral adductor palsy. Now, bilateral adductor palsy was not given in the choices, and that's why that cannot be the correct answer. So, correct answer is bilateral abductor palsy, right? Then we come to question number 5 from the same year. A 3-year-old child presented with fever and biphagic stridor. X-ray was shown. Identify the following presentation. So it's a very, very simple question, straightforward. Almost everybody in that paper got it right. So it says acute tracheobronchitis, acute epiglottitis, subglottic stenosis, foreign body obstruction. So you want to write the answer. The condition is steeple sign. The X-ray is showing steeple sign, also called pencil tip sign. It is seen in croup, and croup is also called acute laryngotracheobronchitis. So A is the correct answer in this case. In epiglottitis, there is thumb sign. We all know this. Thumb sign is another very popular MCQ they ask you. In subglottic stenosis and foreign body obstruction, there are no signs of a particular type. There is no particular sign in these 2 cases, but in the first 2 there is a very important signs. So A is the correct answer. Then we go to question number 6 in the same year. Patient has enlarged tonsil and is unable to swallow. Patient is also complaining of ear pain. Most likely source of pain is auricular branch of vagus, tympanic branch of glossopharyngeal nerve, greater auricular nerve, and mandibular nerve. Now, if the patient has enlarged tonsil and is unable to swallow, this tells you that this is most probably a oropharyngeal problem. This is a problem of oropharynx. So basically they are asking you if there is a oropharyngeal problem and that causes a referred pain in the ear. So which nerve is carrying this pain to the ear in a patient of oropharyngeal disease? So whenever you have this type of question that the disease lies somewhere else, either in the larynx, in the oropharynx, in the mandible, in the tongue, in the oral cavity, and the patient is having ear pain, that means it's a referred pain, then how do you crack this kind of question? You have to tell yourself which is a common nerve that supplies the ear and the site of the disease. The site of the disease in this case is oropharynx. Is there any common nerve in the ear and the oropharynx in this case? And the answer is 9th nerve. Oropharynx is supplied by 9th nerve. And there is a branch of 9th nerve in the ear called Jacobson's. Jacobson's is a branch of 9th nerve that supplies the middle ear. And this Jacobson's nerve is also called tympanic branch of the 9th nerve. So that's why tympanic branch of the 9th nerve, B, is the correct answer. Auricular branch of the vagus nerve is the Adhanepo-Arnold's nerve. And this carries the ear pain from the larynx. So if a laryngeal disease like supraglottic carcinoma or epiglottitis, if these kind of conditions is causing ear pain and they ask you which nerve, then any ear pain from larynx is by the 10th nerve. 10th nerve is a branch of, a 10th nerve branch in the ear is Arnold's. So Arnold's or tympanic branch of the 10th nerve is the correct answer. If there is a ear pain from oropharynx, like we discussed this question, tonsil is a part of oropharynx, then it is the 9th nerve branch called Jacobson's, which is also called tympanic branch of the 9th nerve. And if there is a ear pain from anterior 2/3 of tongue or mandible, then it is the mandibular nerve. So basically 2 things to remember here. If there is a ear pain or referred ear pain from any part of the body, answer has to be one of these 3 nerves, either 10th nerve or 9th nerve or mandibular nerve. There is no 4th nerve that can cause ear pain. from any part, referred ear pain. So it has to be one of the three nerves depending on which part. So it's, if you remember that, it becomes very easy. A lot of people think from the tongue the facial nerve will carry the pain. Now if pain is a symptom, this is the second point of view, if pain is a symptom, facial nerve cannot be the correct answer. Keep in mind, although this is not 100% true, but for your purpose this is 100% true, that facial nerve does not carry the pain sensation. For you that much is true, all that is not 100% true, right? So if you keep this point in mind, these 2 points, that facial nerve does not cause pain, and if there is a referred pain, it has to be either mandibular or the 9th or the 10th nerve, then it's sorted, you are sorted in this particular case. A patient present with progressive growing swelling from the past 2 years, on examination it was dense, mobile and nodular as shown in the image below. What is the most likely diagnosis? So there is a progressive swelling, long standing, 2 years. So it cannot be a malignancies, because malignancies are fast growing, they are very fast growing swellings, not slow growing. And it's a dense mobile swelling, so there is nothing fixed, it is not a fixed swelling, again that rules out a malignancy. And nodular, single nodule, there is not multiple nodular swellings. And the image is more important. This area, the swelling that you see, this area which is just below the lobule of the ear, is a typical area of the parotid gland. So this is a parotid gland tumor. Jaw swelling, obviously jaw is mandible, it's the swelling is here in case of jaw, and this dermoid cysts and sebaceous cysts, they can happen anywhere. These swellings can happen anywhere, but this is a very typical area of the parotid swelling, and the most common parotid swelling in this area is due to pleomorphic adenoma. And usually pleomorphic adenoma is a benign tumor, and that's why it is a slow growing swelling. Usually it does not cause pain, is very uncommon in this case, and also facial nerve involvement is very uncommon in this case. So that's why there is no mention of pain, there is no mention of facial nerve palsy in these patients. Right. Eighth, a child has a head injury for 1 year ago. Now the patient presented with non-axial proptosis in the eye. So identify the mass given in the scan. So there is a MRI and there is a swelling here, and is it pseudotumor of the orbit? So this is outside the orbit, so it cannot be orbital. Ethmoid meningioma. Ethmoid is this area, so it cannot be ethmoidal swelling. This is a very typical area of frontal mucocele, and juvenile nasopharyngeal angiofibroma is nothing to do with injury. So due to injury, the sinus ostia gets blocked, this leads to frontal sinusitis, and frontal sinusitis leads to frontal mucocele. None of the other conditions given has any relation to the trauma except frontal mucocele. And second thing, this is if the swelling is here in the frontal sinus area, it is very typical of frontal mucocele. So frontal mucocele is the correct answer, although actually the image was very different from the one that is given here. So we have completed all the questions from the NEET PG 23, and we come to 22. In 22, question number 1, a patient with asthma developed nasal polyp and sinusitis. Which of the following drug is patient sensitive to? Gentamicin, aspirin, cetirizine, all of the above. I think everybody knows the answer. If you have a triad of asthma, nasal polyp and sinusitis, then the likelihood of Samters triad is very high, and in Samters triad, along with asthma, polyps, the third thing is aspirin sensitivity. So it's a very straightforward question from Samter's triad, aspirin sensitivity. In 22, you'll be surprised to know this was a question regarding Samter's triad in your NEET PG paper, and there was another question on Samter's triad in another question paper. In the FMG, you know that there is a question, foreign medical graduate, people who graduate from outside of India, they come back, they write an example MCI screening test. In that paper also, in the same year 22, there was a question on Samter's triad. It was a different question, but it was definitely a question from Samter's triad. So same year, they had asked two different paper, a question from Samter's triad tells us that Samter's triad is a very important topic that you should be aware of. Next question. A patient started vigorously coughing and was visually seen choking during dinner due to obstruction of the airway by food particles accidentally. Which of the following is your next student? So patient was having meals and suddenly the patient started having choking and coughing. Obviously, there is aspiration of food. Is clear-cut history telling there is aspiration of food. And if there is aspiration of food, what is the next thing that you do immediately? We don't have to, everybody knows, even the non-medicals knows that we have to do Heimlich maneuver straight away. When there is a choking due to food, you have to do Heimlich maneuver. Endoscopy, by the time you take the patient to the doctor and endoscopy, if the airway is completely blocked, then the patient will not even reach the hospital alive. So patient might die on the way to the hospital. So you can't wait for that. And wait and watch, you cannot wait and watch for any aspiration. Aspiration can potential life-threatening conditions, so you cannot wait and watch. And chest thrusts are done for cardiac arrest and all that, not for choking. Yeah, so it's very simple Heimlich maneuver. Like I said, even non-medicals could answer that question. Next question. An 18-year-old male presented with chief complaint of recurrent epistaxis. Now, if a male of this year has epistaxis, straight away you know that we are dealing with angiofibroma. This history will tell you, even last, if you have written the last INI set exam, the first line was the same. There was a question and the same, instead of 18 years, it was 12 years. A 12 years old male child with epistaxis, a 13-year-old male child with epistaxis, 18-year-old male child with epistaxis, straight away angiofibroma comes to your mind. But let's look at the question. There is nasal blockade also. And endoscopy, there is a polypoidal mass in the nasopharynx, from the nose to the nasopharynx, occupying the posterior quena. Quena is a very typical site of angiofibroma. So everything tells you this is angiofibroma, and the image also showing you the same thing. So nasal polyps never bleed, no bleed. Nasal polyp causes no bleed. Rhinosporidiosis is not seen in children, is in adult usually, and not in quena. It is usually not in quena. Right. Ringer's tumor is seen in adults more than 50 years usually. So you lift it, juvenile, nasopharyngeal, angiofibroma. Even otherwise, you know it is angiofibroma, and we have ruled out all the three very easily. So it is straight away angiofibroma. Next, question number 4. A child presents with fullness in the ear and mild hearing loss. So there is fullness in the ear with mild hearing loss. The endoscopic image of the tympanic membrane is given below. Identify. If a child has fullness with hearing loss, the first thing that comes to mind is serous otitis media, because serous otitis media is the most common cause of hearing loss in children. This is another MCQ. They ask what is the commonest cause of hearing loss in children? Serous otitis media. So if a child has hearing loss with fullness, serous otitis media is the first thing that comes to your mind. And on more, the image shows you air bubbles in middle ear. This again seen in serous otitis media. So the straight away serous otitis media. Bullous laryngitis is painful, and there is a bulle on tympanic membrane. On the tympanic membrane there is a swelling, not in the middle ear like in this case. Pneumotympanum is again air in the middle ear, but there is no air bubble. There is no air bubble, there is air in the middle ear, and because the air in the middle ear, there is a bulging tympanic membrane, and It is usually due to trauma, history of trauma and something like that. In tubercular otitis media, there are multiple perforations. The tympanic membrane is never intact like in this case in tuberculosis. So straight away it is serous otitis media. So simple question, no problems. Next one, question number 5. A patient with high frequency hearing loss due to damage to the basilar membrane and structure closest to it. So basilar membrane is a part of the inner ear cochlea, and there is a high frequency hearing loss. If a basilar membrane has a disease and it is causing high frequency hearing loss, that means it is the base of the cochlea. It's a base of the cochlea disease because apex of the cochlea causes low frequency hearing loss, base of the cochlea causes high frequency hearing loss. We all know this one. So which of the following structure is most likely to be injured? So what are close to the base of the cochlea? Close to the base of the cochlea are three things. There is oval window, there is round window, and there is promontory. So these are the three things which are close to the oval window, and if you have disease or problem in any of the three areas, the base of the cochlea can get affected and high frequency hearing loss can happen. So out of the three, in the choices we have oval window, B. There is no choices round window, there is no choice say promontory. So helicotrema is the apex end. Stria vascularis is throughout. So in throughout the cochlea, that means it will cause hearing loss. If there is a problem in the stria vascularis, then it will cause hearing loss in all frequencies, not only high frequency. And semicircular, no hearing loss, will not cause hearing loss, it will cause vertigo because semicircular canal is related to balancing and not to hearing. So if there is hearing loss without vertigo, canal cannot be a problem. Stria vascularis is a membrane that causes hearing loss in all frequency, not specific to high frequency. Helicotrema is the apex end of the cochlea. Problem of the helicotrema will cause low frequency hearing loss. The only area disease that can cause high frequency hearing loss out of the choices is the oval window. So oval window is the correct answer. So if you have attended my lecture, when I draw the pinna canal in the middle ear, there is oval window, there is promontory, there is round window, right? There is a tympanic membrane here. So this is the oval window, this is the round window, and this promontory. And inside there is cochlea like this. Now if you open the cochlea, if you imagine that you made the cochlea straight, the cochlea if it's like this, opened up, then this end is the base end of the cochlea and this end is the apex end, and this connection is called the helicotrema. Apex is for low frequency sound, base is for high frequency sound. So the question clearly says it is a high frequency hearing loss, that means the problem is this area, and this area is close to round window, promontory, oval window. I told you if you have problem of any of the three, the base will get affected and high frequency hearing loss will happen, and out of the three in the question there is a oval window in choice, so oval window is the correct answer. Right. Next one. A diabetic patient presented with rhinitis and facial swelling, and intranasal biopsy revealed a presence of broad base aseptate hyphae. Broad base aseptate hyphae with branching at right angle is very highly suggestive of mucormycosis. Due to rhizopus. So this is mucormycosis that is caused due to rhizopus, and they are asking the drug of choice. So drug of choice for rhizopus in mucormycosis is liposomal amphotericin B. So in this case, amphotericin B is given in the choices, so that becomes your best answer out of the lot. So it is the drug of choice. This is the drug of choice in mucormycosis. So this becomes your correct answer. Next, a patient presented with angle of the mouth deviation to right, drooling of saliva, inability to blow the mouth, unable to close the mouth. So there is a facial palsy basically. Facial palsy, isn't it? Very straightforward, simple question. It is caused due to facial nerve, 7th nerve. 9th nerve has nothing to do on the face. 9th nerve is no relation to the face. 5th nerve is sensory on the face. It is not motor. These are facial palsy, motor palsy basically. That's why the patient is unable to close the mouth, blow the mouth and all that. So it's a motor palsy. And 3rd nerve again not on face. It may supply the eye but not the face. So it's straightway simple question. I don't think there is any problem. So we have completed all the questions from NEET 22. Then we come to 21. A woman presented to ENT OPD with complaints of nasal obstruction. On examination, greenish black crust seen in the nasal cavity covering turbinates and septum. She has merciful anosmia. So if a woman complains of nasal obstruction, it could be anything. But if there is a black crust, greenish black crust with merciful anosmia, these two tells you it is atrophic rhinitis. In atrophic rhinitis, typically there is a greenish black crust, and merciful anosmia is a very popular feature of atrophic rhinitis. Everybody knows. So the diagnosis is not difficult. So which of the following is a feature of atrophic rhinitis? Roomy cavity. So there is roomy cavity in atrophic rhinitis. There is dry cavity. There is crust formation which is given in choices. There is anosmia which is called merciful anosmia. There is foul smell and may bleed. These are the features of atrophic rhinitis. Out of these 6 features possible, only one is given in the choices, which is roomy cavity. So that becomes the correct answer. Atrophic rhinitis has nothing to do with polyp, has no relation with foreign body, and hypertrophy is opposite of atrophy. How can atrophy cause hypertrophy? They are opposite terms, isn't it? So it's out of question. Atrophy is out of question in atrophic disease. So A is straightforward the correct answer. In atrophic rhinitis, they ask you merciful anosmia. They ask you about alkaline nasal douche. They ask you the name of the surgeries like Young's operation, modified Young's operation. So read this topic very nicely because this is the most important rhinitis from the exam point of view. Very commonly asked rhinitis from the exam point of view. But we'll go to the next question. Question number 2 from 21. A 35-year-old male presented with epistaxis. So again epistaxis. In adult, conservative management was done to stop the bleeding. Conservative means like you do nasal pinching, cautery, packing and all these are conservative management, and they have all failed. So what is the next line of management? So in epistaxis, how do we treat? The first thing we do is nasal pinching. If this fails, we do cautery. If this fails, we do packing. And if this fails, ligation. Right. So this is the sequence. So all these 3 are conservative management. So they've all failed. So we have to do ligation. And the first artery that we ligate is the sphenoplatean artery. And so we do endoscopic sphenoplatean artery ligation. It is also called TESPAL in short, because we do transnasal endoscopic. So T stands for transnasal endoscopic sphenoplatean artery ligation is done as the first artery. If this fails, then we ligate maxillary artery. If this fails, we ligate external carotid artery. And if this fails, then the last step is the anterior ethmoidal artery ligation. We never ligate the internal carotid artery, never. There is no indication for internal carotid artery ligation because internal carotid is the supplier of the entire half of the brain. So if you ligate the internal carotid artery, the opposite half of the brain is completely shut off, and this patient will lead into hemiplegia, isn't it? So you cannot ligate the internal carotid artery, right? So I hope that you guys are following it properly. If there's any question or doubt, please answer that. Please ask me online on the YouTube. Okay. A patient of thyroidectomy was bleeding, being extubated. So patient has undergone thyroidectomy surgery. After the surgery, we have to extubate, being extubated. The anesthesiologist realized that when you remove the tube, the patient begins to have recurrent cyanotic spell or dyspnea. Cyanotic spell and dyspnea are one and the same thing. So which of the following could be the cause of this? Bilateral recurrent nerve palsy, superior nerve palsy, unilateral recurrent nerve palsy, hemorrhage. So what do you think is the correct answer? And Life of Tintin, very nice name, says A is the correct answer. What do you think, guys? Is A the correct answer? Is Life of Tintin correct? Tintin is an outdated magazine or whatever. We used to read this when we were kids, very fond of Tintin. But now, after social media, Tintin has taken backstage, and there are so many other things in the forefront. So Dr. Samir says A, Cetralina says A. So yes, A is the correct answer in this case. Bilateral recurrent. I've discussed this. See, again the same thing. I'm repeating what I told you in one of the questions previously, that if there is a recurrent palsy and vagus palsy are the two most common kind of palsy. Recurrent nerve palsy leads to abductor palsy. Vagus palsy causes adductor palsy. Both can be unilateral or bilateral. This can be unilateral or bilateral. And in unilateral abductor palsy there is hoarseness, no dyspnea. Bilateral abductor palsy there is dyspnea. So this is the answer. In unilateral abductor palsy again there is hoarseness with maybe aspiration. In bilateral abductor palsy there is aspiration with aphonia. So the only condition which of vocal cord palsy which has dyspnea is bilateral abductor palsy, and that's why bilateral abductor palsy is the correct answer. Yes, sertraline is correct that in this case only cricothyroid muscle is still functional, and rest all of the muscles gets paralyzed because they all supply by recurrent laryngeal nerve except cricothyroid muscle, which is a very common knowledge. Everybody must be knowing this. Right. Okay. A post-tonsillectomy child was lying in the ward. He started bleeding in the ward. Which of the following should be done? So if the patient after tonsillectomy is in the ward, most probably this is reactionary bleeding. So in reactionary bleeding, basically, what is the correct answer, guys? Write in the choice. Is take to the OT, remove the clot and religate, take to OT and pressure packaging, cautery, conservative management. So what do you think is the correct answer according to you? Of course, conservative cannot be the answer. Any bleeding, in any bleeding, conservative is never the correct answer. Bleeding is like an emergency, so you have to do something. And there are people saying A. So sertraline is saying A, Life of Tintin A, Anjuza Jayan A, Samir Doc A, Firoz Ali Khan B. Firoz Ali Khan says B. Stuti Prasad says A. So in reactionary bleeding, you have to do religation. A is the correct answer. Reactionary bleeding is sudden and severe. This is done for primary bleeding. So Firoz Ali Khan, if I am pronouncing your name correctly, B is the correct answer if it is primary bleeding, because the patient is already in the ward. That tells you that surgery is over. After surgery, the bleeding is reactionary bleeding. So this is a case of reactionary bleeding, and in reactionary bleeding, religation is done, not packing. Okay. So this is that chart that I've made for you. Bleeding of tonsillectomy can be primary, reactionary, and secondary. Primary bleeding happens during surgery. So this is not during surgery. Surgery is over, and then we do pressure apply pressure, right? But that is done in primary bleeding, like I told you. Now this is within 24 hours. So this is a reaction bleeding and immediate religation under GA in OT. So this is the correct answer in this particular case. Secondary bleeding happens in 5 to 8 days, and in that case we give antibiotics mainly. So this particular table slide is extremely important slide. They ask you questions from here very commonly, okay. So please take a screenshot if you don't have this slide, and remember this slide, very important. Please take a screenshot if you don't already have this slide from the class notes. Next one, a patient has undergone a submandibular gland excision and Wharton's duct was ligated. We all know the gland, the duct of the submandibular gland is called Wharton's duct. Okay. So which of the following nerves is most likely to be damaged? Inferior alveolar nerve, hypoglossal nerve, lingual nerve, nerve to mylohyoid. So what is your answer, guys? In this case, if you are doing a ligation of the Wharton's duct, then which of the following nerves may get damaged? So any answers you want to answer this question? Is it inferior alveolar nerve, hypoglossal nerve, lingual nerve, nerve to mylohyoid? So I can see lot of C. Cetrilina says C, Anuja, Dr. Samir, Arpit Yadav lies near submandibular gland. She says life of Tintin is C. Zenon says A. So there is one different answer, A. Anu Moyal says C, and Arpit says auriculotemporal lingual is a branch of auriculotemporal is not given in the choices. Arpit Yadav, what do you want to say when you say auriculotemporal? Auriculotemporal is not given in the choices, my dear friend. Where does it come from? Auriculotemporal. Please write in the comment, Dr. Arpit Yadav, why did you say auriculotemporal nerve? It is not mentioned in the choices. Are you trying to say that lingual nerve is a branch of auriculotemporal nerve? And that is not true. Lingual nerve is a branch of both auriculotemporal and lingual nerve, both are branches of mandibular nerve, right? So lingual is the correct answer because like Cetrilina says, it lies close. Not only lies close, it crosses this duct. Look at this image that I have produced for you. Now this is the floor of the mouth, the muscles in the floor of the mouth. You can easily make out the mandible and the muscles and the hyoid bone. This is the hyoid bone. This is mandible and the muscles in the floor of the mouth. Now this is the submandibular gland duct, submandibular gland, and this is the duct. So this duct that you see here is a submandibular gland duct, and this is the nerve that is crossing this duct, this nerve, and this nerve is the lingual nerve. Okay, that's why lingual nerve is the correct answer. So not only it is close to it, it is crossing the duct. Lingual nerve is crossing the duct, as you can see in the image, and that's why it's highly likely that it is damaged. Now let me give you one more fact about the excision of the submandibular gland. Do you know where is the incision given in the case of excision of the submandibular gland duct? When you do the excision of the submandibular gland, where is the incision given? The incision is given where? 2 fingers below the border of the mandible. Two fingers below the border of the mandible here. You know why? And then you raise the entire skin with the platysma. You don't raise the skin and then platysma. The skin and the platysma, or the, you can say the fascia, is raised together. You know why? Because the cervical branch of the facial nerve is running here. So when you do excision of submandibular gland, 2 nerves can get damaged. 2 nerves. one is cervical branch of facial nerve, but this gets damaged while giving the incision. It has nothing to do with the duct. And second is lingual nerve. As we discussed, this gets damaged while you are ligating or the duct. When you are cutting the duct, then this nerve gets damaged. So both can get damaged. Although cervical branch of the facial nerve is not given in the choices, so that can never be the correct answer. But this is a additional information that I want to give you just in case. Okay, so they may ask you that why do you give the incision of the submandibular gland duct excision 2 fingers below the mandible to preserve this nerve, cervical branch of the facial nerve. Okay, not greater auricular. It's not greater auricular. Greater auricular lies between the tip of the mandible and the angle of the mandible, tip of the mastoid and the angle of the mandible, between the two, here. Greater auricular nerve lies here, not here. Okay, this is a very simple question. Patient with history of chronic ear discharge, now present with ear pain, headache and vomiting. Brain MRI is shown. So probable diagnosis. So it's straightforward, isn't it? Now you can see the image. So chronic ear discharge is CSUM, and if it is pain, it's more likely to be unsafe. Safe does not cause pain, unsafe causes pain. And headache and vomiting means intracranial spread. There is a intracranial complication because of headache and vomiting. And in the image you can see the temporal lobe abscess. So yes, actually, you know what, in this case, yes, encephalitis or meningitis is a better term we can use there. In this case, both are B and C, both are correct answer. Temporal lobe abscess is a cerebral abscess, isn't it? So both are correct answer, but more specific is temporal lobe. So if temporal lobe is not given, then cerebral abscess can be taken as a correct answer also. So if I ask you, where do you stay? Suppose you are staying in Delhi, like where do I stay? I can say I stay in India, I live in India, which is correct answer. If I say I live in Delhi, which is also correct answer. But Delhi is more specific than saying India. So that's why if there are two choices, India and Delhi, Delhi is a better answer. Similarly here also, cerebral abscess can be a correct answer, but temporal lobe will be the better answer. Right. If you want the PDF file, send me the group. Where should I share this PDF file? Tell me the group. Okay, I will share the PDF file. So this will complete all the questions from NEET 20. So we have done 23, 22, 21 and now 20. A patient has undergone the canal wall down mastoidectomy. We all know mastoidectomy can be canal wall up, canal wall down, MRM. For colostoma, it's very commonly done for colostoma, which is unsafe CSUM. So the patient is unsafe CSUM colostoma, and where canal wall down mastoidectomy is done, which leads to enlarged meatus. Now tell me the name of the surgical procedure which involves reconstruction of the cartilaginous part of the external auditory canal: canaloplasty, meringoplasty, tympanoplasty, meatoplasty. So guys, you want to answer this? You want to answer this question? So in canal wall down MRM, if you make the enlargement of the meatus, so obviously the name meatus is given there, and so it has to be meatoplasty. Meatoplasty. So canaloplasty is surgery of external auditory canal. Meringoplasty is surgery of tympanic membrane. Now these terms are very important, guys. Tympanoplasty is surgery of middle ear, and meatoplasty is surgery of meatus. Right. Now meatoplasty is done in two surgeries. One is canal wall down, which is the question. Any other surgery where meatoplasty is done? Can you name the other surgery where meatoplasty should be done? So Somaiya Shyam is correct when he says tympanoplasty is oculoplasty plus meringoplasty. Absolutely right. Somaiya, you are absolutely right. So I'm asking you, can you tell me the other surgery where meatoplasty should be done? One is canal wall down, which is the other surgery where you should do meatoplasty also. You want to answer this question, guys and girls? Let's see who wants to answer this question. Please someone answer this one. The other surgery where meatoplasty should be done. No one? Radical mastoidectomy. So these are the only two surgery where meatoplasty is done. In atresia, Somaiya Shyam, in atresia we do canaloplasty, not meatoplasty. In atresia we do canaloplasty usually. Maybe meatoplasty also. But when they ask you meatoplasty should be done after which surgery, there are two correct answers. Either canal wall down MRM or radical mastoidectomy. Right. See, in canal wall down MRM and radical mastoidectomy, we have to do meatoplasty in both these surgery. Why? What is common in these two surgeries that we have to do meatoplasty? There must be something common in these two surgeries because of which we do meatoplasty in both these surgeries. So what is the common thing? In both the surgery, we remove bony posterior wall. And if you remove bony posterior wall, then you have to do meatoplasty. Right. So the rule is, if you remove the bony wall, posterior bony wall of the ear, you have to do meatoplasty. And there are only two surgeries where you remove the bony posterior wall, which is canal wall down and radical. Second question related to this is, what is the advantage of doing meatoplasty in these two patients? In the patient of canal wall down MRM and in a patient of radical mastoidectomy, what is the advantage of doing meatoplasty? Can you tell me that? Why should I do meatoplasty after canal wall down MRM after radical mastoidectomy? Why? Advantages. Meatoplasty advantages. Anybody wants to answer this question? Advantage of meatoplasty? If I am doing meatoplasty, it must be having advantages. So now you are, everybody now, those who have read, they know that radical and posterior wall removal, all okay, all that is okay. But advantage, my dear friends, advantage. What is the advantage? Prevents infection is not correct, my dear friend. Two advantages. One, better drainage. The drainage is better. That's what Modison Hanglem, I hope I am pronouncing your name correctly, Modison Hanglem is correct. One. Second advantage, Modison, do you know the second one also? First one you have correctly answered, Modison. Can you answer the second one also? easy examination during follow-up. When the patient comes after the surgery for follow-up, then it is examination becomes easier. So it has nothing to do with parotid and all that. Okay. So these are the correct answers. This is the only thing you have to know about myotoplasty. So everything that you have to know about myotoplasty, I've told you from there. So there is nothing new thing left. So remember all these things, okay, about myotoplasty. But let's just go to the next question. A patient of 25 years male came to AIMS OPD with fever and difficulty in swallowing. And you can see the examination. So straightforward diagnosis: peritonsillar abscess, parapharyngeal space abscess, retropharyngeal space abscess, Ludwig's angina. So what is your answer, the guys and girls? Please write the answer. Second question in 2020. Peritonsillar abscess, parapharyngeal space abscess, retropharyngeal space abscess, Ludwig's angina. So this is enlarged tonsil up to uvula, isn't it? And this is very typically seen in quinsy, which is the other name for peritonsillar space abscess. So yes, most of you have got Sikha, Anuja, Simu2, Dr. Jaj, Life of Tintin, Cetralin, Lothitha Priya, Suhana, and Somaya. So these people have got it correct. Firoz Ali Khan got it wrong. And yes, Simu, you are right that if there is a swelling in the neck, then there is a parapharyngeal space. So Ankit Rana, Anu Moyal, Rishabh. Yes, Anu Moyal, you are right. It can push the uvula to the opposite side also. That's true. Anu Moyal, you are absolutely right. It can push the uvula. Now look at these images. This is quinsy swelling. And this is swelling of parapharyngeal space abscess. This swelling is defined as fullness So this swelling is defined as fullness behind the angle of the mandible and this swelling is typically here, is a parapharyngeal space abscess, and this is Ludwig's angina. Swelling below chin. So somebody had said Ludwig's angina. So please note, Mr. Khan, Dr. Khan, I forget your name. So Dr. Khan, I forget your name. This is the image of Ludwig's angina. Okay. And this is parotid swelling. So now you can see all the four images. So Suhana Prohit, can you see the swelling in the parotid? So if you look at the images now, you can easily make out the swellings of these four conditions. So there is a first one is a swelling of quinsy. Quinsy will never cause swelling outside. Quinsy swelling is always inside. As you can see, tonsil is enlarged. And somebody was asking me the grade. Suhana Purohit was asking grade. In quinsy there is no grading. Grading happens in tonsillitis. Okay, this is not tonsillitis. This is quinsy. Okay, tonsillitis has grading. Quinsy has no grading. And tonsillitis are usually bilateral. Bilateral tonsillitis One may be more than the other, but usually bilateral. In tonsillitis, there is a simple inflammation. There is no collection of pus. In quinsy, there is a collection of pus, and that's why there is a too much of push of the tonsil. So there is no grading in this case. So please look at the 4 swellings, and I'm pretty sure they're very important, very, very important. We have discussed parotid swelling a little while ago, which was asked already in the exam. So they can ask you all these swellings. So please make a note of these guys. Okay. Now, a 20-year-old female was moving towards her home by 2-wheelers. Suddenly she fell down and had a fracture in the middle cranial fossa. So it's a middle cranial fossa or temporal bone fracture. Middle cranial fossa is mainly comprised of temporal bone. Mainly, not always, not entirely, mainly. So identify the sign that is seen. So you can see the blue skin on the mastoid area. Battle sign, Bayer sign, water balloon sign, gray singer sign. So what is the answer? So I can see a lot of A's. So Firoz Ali Khan says A, Setrilina says A, Simu says A, Sikha Yadav A, Dr. Jaz A, RJ A, Lohita Priya A, Mithali, Xenon. What is Xenon? Battle sign. Okay. Anuza A. So everybody A. Divya, Asutosh, Life of Tintin, Anu Motal, Xenon, Suhana. Yes. Nazir, battle, not battle, Nazir, spelling ठीक करो. Ectopic bruise, ठीक है. So everybody, not mastoiditis. No. Loita, it is not mastoiditis. So please, in mastoiditis, they smooth and shiny skin, and it is called ironed out mastoid. This is the description. Okay. So please note, Lohita Priya, this is for you. In mastoiditis, there is smooth and shiny mastoid. There is no blue color. History of trauma, fracture of temporal bone, blue mastoid, and this is battle sign. So this is blue, so this is battle sign. And if it is edema in lateral sinus thrombosis, there is edema of mastoid, and this is called gray singer sign. So mastoid skin, these are 3 signs. Okay. Acute mastoid is a complication of CSM, whatever. So gray singer sign will have edema. Bayer sign is seen in laryngocele. It is in neck swelling. And water balloon sign is seen in Rinke's edema. This is vocal cord, edema of the vocal cord. Yes. Delta sign, SIMU2 is correct. Delta sign and empty delta sign, both are feature of lateral sign, but there is a CT scan MRI finding. Right. So you know a lot of stuff. Correct. So everybody is correct. This is a very simple question. It was asked in 2020. That tubercular otitis media is characterized all except painful otorrhea, multiple perforations, pale granulations and foul smelling water like discharge. So what is your answer in this one? Very simple, I think. Tubercular otitis media is characterized by all except. So what do you want to say? Please answer. So Modison says A, Cetilina says A, RG says A, Cetilina says okay, Simu2 A, Lohita Priya A, Sikha, Mithali, Zinon, Ashutosh, Suhana, Sikha again, Cetilina, Firoz Ali Khan, Anuza, Jayan, Nazir Sheikh, Roy, Gamer, Rithika, Vivakasri, Ankit Rana. So everybody got A. Tubercular is painless. So straightforward. So there is nothing here. Painless. So see another question. Another question. See, you know how important this similar question was asked in 2021, I think, 22, I think, and now again 20. See, such an important question. A child was brought to doctor along with the X-ray, complaint of barking, cough, fever, hoarseness of voice, and labored breathing, typically worse at night. X-ray of the patient is showing stipple sign. They are telling you stipple sign, and this is seen in what? Croup, and croup is, I will not wait here, laryngotracheobronchitis. No, in acute cough it is thumb sign on X-ray. In laryngomalacia it is omega shaped, epiglottis, and in laryngeal web there is just a web in anterior commissure area. Right. So this is straightforward. Croup, viral disease, LTB, everything is simple. Everybody knows about croup in details, but croup is a very important topic. This is what you understand. Croup and acute acute epiglottitis, both are extremely important topics. See, same year, same paper, there was 2 inflammatory diseases, one in larynx, one in ear. Occipital with mouth open to check for nose, paranasal, sinus is Waters, Cardwell, Towns, PRSV. So what is the answer to 6? So A, I can see Lohita is A, Zenon is A, Sikha is A, Simu2 is A, Cetilin is C, Dharna Gandhi is A, Srija Pudari D, Asutosh A, Anur A, Roy the Gamer A, Nazir D. So Nazir has got it correct, and Sreja is correct, Nazir is correct, D is the correct answer. D. Mouth open, PRSV. See, occipito mental view can be with open mouth, with closed mouth. With open mouth it is PRS view, with closed mouth it is Waters view. So because the question clearly says open mouth, therefore PRS is the correct answer, not Waters view. Okay. So Srija got it correct and Nazir, 2 people got it correct, most of you got it wrong. So please make a correction here. This is occipitomental view. This one is Waters view. Closed mouth. This is PRS view. Open mouth. Okay, be very sure about this. Be very, very sure. Don't make that mistake again. A patient came to ENT clinic with symptoms of crusting in the nasal cavity, nasal obstruction, nasal bleed, and told the doctor his wife sleeps away from him because of the strong foul smell coming from the breath. Doctor advised him partial closure of the orifice, done in which condition? So this is a very clear cut of what? Is it atrophic rhinitis, chronic fungal aspergillosis, vasomotor rhinitis, fungal mucormycosis? So please write the answer to question number 7. What is your answer to question number 7? So this is clearly atrophic rhinitis. So most of you have got it correct. A very typical, so atrophic rhinitis, again 2 questions in the gap of 3 years. They've asked question on atrophic rhinitis in 2 questions. Yes or no? So once again, this surgery, partial closure of the orifice, as Anu Moyal is correctly saying, is a modified Young's operation. Correct. So A is the correct answer. Very typical history of a atrophic rhinitis. So see, steeple sign has been asked twice, atrophic rhinitis has been asked twice in the 3-4 years, vocal cord palsy related question has been asked twice. So one of the things that you understand from these kind of sessions, they will not repeat the same question, but you know which are the common topics that you have to really be very, very careful about. So this is one of the takeaways from all these PYQ sessions, that you know the important topics. If similar topic has been asked more than once, that is the topic you have to know by heart. Put all your energy in those topics, isn't it? Stimulation of the external aortic canal leads to cough due to which nerve? Again, see, similar question. I told you already. If there is a relation of the ear and the larynx, this is coughing is due to larynx. So ear and the larynx, which is the nerve? Auricular branch of the vagus, greater auricular nerve, auricular temporal nerve, or facial nerve? What do you say? Ear and larynx. Yes. So I can see A, Divya says A, Khan Bhai says A, Setrilina says A, Sreja says A, Khan Bhai again A, Sikha A, Simutu A, Firoz Ali A, Dr. AD A, SP A, Lohita A, Roy the Gamer A, then Anuj A, Ritika A, Simutu A, Dharna Gandhi A, Divya, Anu Moyal, Dharna Gandhi again, SP, Jomo Medicos, Suhana, Ashutosh A, everybody. So because we have discussed this before, so again this tells you it is important topic, isn't it? If there is a relation of the ear and any other part of the larynx, it is 10th nerve, oropharynx 9th nerve, tongue and the mandible and the TM joint is auriculotemporal mandibular nerve. That's it. We have done this before. So a 45-year female diagnosed with benign neoplasm, and the doctor has advised her to remove that mass for which she has undergone a parotid surgery, not a surgical landmark for parotid during parotidectomy. Basically, they are asking you which of the following is not a surgical landmark for parotidectomy surgery. So what is the answer? Inferior belly of the omohyoid, tracheal pointer, digastric, posterior belly of the digastric, and facial nerve dissection from the peripheral branches. So how to maintain cool and calmness in the exam? The best thing to tell yourself is, I have done my hard work, I have done all the hard work, अब ऊपर वाले के हाथ में छोड़ दिया. Last day of the exam, you tell yourself, I have done all the hard work, I put in my best effort, I have attended the lectures, I have made notes, I have revised them over and over, solved a lot of MCQs. यही करना है सबने. Once you have done all the hard work, on the last day, don't think याद है कि नहीं याद है, don't think कितना याद है, क्या छूट गया, क्या नहीं छूटा. Don't discuss with others what have you read, what are you reading. Don't discuss with others, just chill and leave it to the Almighty God. Last day you can't do anything, just God has a plan for you, leave everything to Him. Go to the exam, give your best shot, give you 100% in the exam with a cool mind. Don't think about the result. Don't think कि कितना पढ़ा है. Don't, think about the past. Don't discuss with your friends. That's the best thing you can do. Just go and give it your best. Yes. So inferior belly of the omohyoid. Now this is the list of the landmark for facial nerve. The first one is for middle ear surgery, and the second one is a landmark for parotidectomy surgery. So I'll give you the PDF file of this, so you'll get this list from there. So if you don't have this list already, you can read from there, or you can take a screenshot right now if you want to. Okay. Inner ear of human consists of three parts: cochlea, vestibular and semicircular canals. Saccule develops from which of this part? Saccus anterior, saccus posterior, pars superior, pars inferior. What do you think? What is your answer? Saccus anterior, saccus posterior. Saccule of inner ear develops from. So what do you want to say about this? Saccus anterior and posterior, they lead to spaces in middle ear, and this is not important. So yes, pars inferior. So most of you have said pars inferior, which is the correct answer. So when I ask you inner ear development, inner ear has two parts. They develop from two parts: pars superior, pars inferior. These are the three things that come from pars superior. These are the two things that come from pars inferior. Saccule was the question, and saccule comes from pars inferior. So Khan Bhai says saccule and the cochlea both come from pars inferior. You know the answer correctly. Absolutely. So simple question. So we have completed 2020 and then we go to 2019. Few questions from 2019. Now identify the lesion of the vocal cord. This is a vocal cord, they're telling you. Identify the lesion. Is it Rinke's edema, laryngeal papilloma, malignancy, or tracheomalacia? What is the answer? Identify the lesion of the vocal cord. Rinke's edema, laryngeal papilloma, malignancy, or tracheomalacia. So I can see a lot of B's. Sertulina says B, Sreza, Simu2, SP, SP was wrong. Luffy, Nazir, Tanuza, Anuza, both. Pranav, Firozali, Anum, Sreza, Ritika, Divya, Dharna, Gandhi, Domo, Jomo, Anu, SP, Khan Bhai, Farah Fayaz, Modisan, Sahana, Soni, Lohita, Nazir, Ayush, Gautam, Naveen, Suhana. So yes, papilloma is the correct answer. This is a very typical papilloma. In Rinke's edema, there is water balloon glottis. We have discussed this already. Malignancy is a proliferative growth. Or ulcerative. And tracheomalacia is a disease of trachea. Not larynx. The name tells you tracheomalacia is a disease of trachea. This is larynx, so it cannot be absolutely wrong, isn't it? So D can never be the correct answer. So everybody who answered got it right. Okay. A child with history of severe pain in the throat, with hoarseness of voice, with high grade fever and toxic look, hoarseness of voice. And the image is shown with there is a membrane. So is it membranous tonsillitis, follicular tonsillitis, diphtheria, aphthous? So I can already see a lot of C's: Leo, Messi, Anuza, Mithali, Khan Bhai, Luffy, Setrina, Pranaz, Firoz Ali says D. Firoz Ali ने D बोला. आशुतोष C, दिव्या, चाना, खान भाई, सोनी, जोमो, अनु, नवीन, सिंधु, Simu, Suhana. So most of you have said C, only one person has said D. So C is the correct answer. This is a very typical diphtheria. Now, rest of them, rest cannot cause toxic look and hoarseness. Rest cannot cause toxic look and hoarseness. Only diphtheria, because diphtheria produces neurotoxin, and neurotoxin will do recurrent laryngeal nerve and is involved, and therefore hoarseness and toxic look. Okay, the rest of them cannot cause toxic look. So it is mainly in the history. It's mainly in the history. So somebody is asking me, how can you differentiate? Cetrina is asking, how can you differentiate with membranous tonsillitis? These are features of so if this answers your question, if this answers your question, Cetrina, that membranous tonsillitis is whitish, not gray, it is a true membrane, it will not spread. This is spreading, look at the image, it is spreading out of the tonsil into the soft plate in the uvula. A membranous tonsillitis cannot spread out, it will not bleed. Membranous tonsillitis will not bleed on removal, it causes no bull neck, no hoarseness, no toxicity. Right? Yes. So this is straightforward. Name the maneuver shown in the image. Brand, Derhoff, Apples, Foster, Dix, Hallpike. So what maneuver is this? Brand, Derhoff, Apples, Foster, Dix, Hallpike. I think this is straightforward. There should be no problem, but I'm still waiting for your answers. Let's see. Firoz Ali Khan is asking, aphthous ulcer either uvula, buccal mucosa, tongue, or lip. This is the site of, this is not in tonsil. Aphthous ulcer cannot be seen in tonsil. Okay, Firoz Ali was asking how does aphthous ulcer look different. One of the thing is tonsil cannot have aphthous ulcer. So everybody has got it right. This is Apples maneuver, straightforward Apples maneuver. Right. A patient presented with the following picture of tympanic membrane, most probable diagnosis: tubercular otitis media, syphilitic otitis media, Pseudomonas infection, fungal otitis media. So what is the answer this time? So I can see lot of A's: Luffy, Semu, Setrina, Tanuja, Divya, Lohita, Nazir, Sikha, Firozali, Mithali, नवीन. नवीन क्या लिखा तुमने? नवीन चेक किया. सेटिलिना, मल्टीपल परफोरेशंस, एसपी, खान भाई, जोमो, सिद्धू, अनुजा, रितिका, नवीन कुमार, सुहाना, शिखा. So yes, there are multiple perforations. And we all know multiple perforations are seen in tuberculosis. So again, tuberculosis, there are two questions in 3-4 years. So it's very, very important otitis media, tuberculosis. Multiple time question they've asked, isn't it? Inspiratory stridor is found in which kind of lesions? Supraglottic, subglottic, tracheal or bronchus? Inspiratory stridor. Supraglottic causes inspiratory stridor. Subglottic either expiratory or biphasic. These two will cause rhonchi and not stridor. So A is the correct answer. So yes, everybody got it right. R. Ritika, you asking presentation for which one? R. Ritika, kindly explain other presentations also. If you are asking for this one, I've already written. If you are asking this one, they will all cause single perforation. This causes multiple perforation. If you're talking about perforation, then this is the answer. If you're talking about this one, I have already written here. So previous question, all other will cause single perforation, only tuberculosis will cause multiple perforation. That's how you can differentiate tuberculosis from any other middle ear infections. Next question, the most common site of bronchial cyst: posterior border of the sternocleidomastoid, anterior border of the sternocleidomastoid, digastric muscle, omohyoid muscle. So which is the most common site of bronchial cyst? You want to answer this question? So I can see a lot of B's here. I can see Simu 2 says B, health for you Bengali, B for Bangla, Modison B, Settling A, Settling says A, B, Anuja B, Naveen B, Asutosh B, Setlina B, Firoz Ali Khan, Samana Sethi B, Dikshita Goyal B, SP B, Divya B, Ritika B, Jomos B. So yes, B, and as Simut says, on upper 1/3. Correct. That's absolutely correct. Upper 1/3. Correct. Okay. So that will complete 19. High tracheostomy is done in the patient with consideration of the following in future. High tracheostomy is done for which of the following conditions? Diphtherial infection, carcinoma larynx, papillomatosis, vocal. It's a very simple question. Biphasic stridor is seen in subglottic stenosis. So this is for you, Dr. Abhishek. Biphasic stridor is seen in subglottic stenosis. So I can see lot of B's. So yes, carcinoma larynx is the only indication of high tracheostomy. Carcinoma larynx is the only indication for high tracheostomy. Otherwise, tracheostomy is done in ring 2, ring 3. That's correct. Nazir Sheikh. Stimulator of the auditory brainstem implant is placed in recess of the fourth ventricle, scala tympani, oval window, external auditory canal. So again, very simple because the choices are very foolish, some of them. So the stimulator of the auditory brainstem implant is placed where? Recess of the fourth ventricle, scala tympani, oval window, or EAC. So what is your answer? Eagle's eye says B, Morrison says A, Suru says A, Setrilina says A, Gautam says A, Lothina Priya says B, Divya says C, Asutosh says B, Mnemonics C, Vivaka Sri says B, Sindhu C, Dr. Poo C, Sikha Yadav C, Sekhar Nazir Sheikh A, Zomo Medico B. So this time we have lot of A is the correct answer. Stimulator of brainstem implant, and scala tympani we place the stimulator of cochlear implant. In these two, no stimulators. So for those who said B, you are confusing with cochlear implant. So be careful. Through round window. This is through round window, not oval window. Simu, not through oval window. Simu 2, it's through round window. Make your correction. See, talking about stridor, supraglottic example, acute epiglottitis, laryngomalacia, inspiratory. Glottic disease like carcinoma, papilloma, Rinke's edema, they will cause biphasic stridor. And subglottic disease like subglottic stenosis and croup they will cause expiratory stridor. So remember this. So you remember this, and that should solve your BIVU aria. If you remember this BIVU aria, I have given you which part of the larynx and the common examples of all these areas causing different part of Suhana Purohit. Yes, vocal cord nodule and vocal cord polyps are very important topics, but they are very simple topics, so this should not bother you. I don't think it should be a bothersome thing, because it's a very vocal cord nodule and vocal cord polyps are very simple topics, so it should not be a problem. So which of the following is the tensor of the vocal cord? Straightforward, simple, asked many times. Questions from the muscles of the larynx, they'll ask you like this, which is the only abductor, which is the tensor, like this. So it's a very simple question, but they ask you commonly, so you should be very sure about the muscles of the larynx and their functions. Simple thing but important thing. So guys, what is your answer now? Question number 3 from 18. Is it posterior cricoarytenoid, lateral cricoarytenoid, thyroarytenoid, or cricothyroid? So Catherine Lal says D, Nitish says A, Simu2 says D, Mithali D, Eagles D, Trickfotat D, Rishabh D, lot of D, Batman, Suhana, Lohita, Sindhu, Simu. Yes, so D is the correct answer. This is the main tensor. This is the only abductor, and these two are adductors. So D is the correct answer. Adductors. Okay. It's a straightforward, simple question. Again, Waters view. So you know how important are X-rays of the sinuses. This is the third question from the X-ray of the sinuses. So this tells you Rishabh Mittal, please, what are you trying to say? Also tensor, which one? Posterior cricoarytenoid is only abductor, no tensor. So yes, maxilla, Waters view, frontal sinus, Cardwell's view, sphenoid sinus, Pierre's view, ethmoidal sinus, these are the view for different sinuses. So thyroarytenoid muscle has two parts, lateral and medial. The medial part of the thyroid retinoid is called vocalis, which causes tension. It's a weak tensor. And the main thyroid retinoid is adductor. So overall, thyroid retinoid is adductor plus tensor, in case there is a confusion. For Rishabh Mittal, look at the mouth open, mouth closed. This is the difference between Waters view and Pierre's view. Mouth closed, Waters view, mouth open, Pierre's view. This is the only difference. Okay. Vocal nodule, treatment of choice is voice rest. If they ask you a one-line question, the treatment of choice for vocal nodule, then you say voice rest. But vocal nodule has two stages. Early nodule, late nodule. Early nodule, voice rest. Late nodule, micro-laryngeal surgery, MLS. Right. So, to answer your question, Nazir Sheikh, that if they ask you the treatment of choice for vocal cord nodule, then voice rest is the correct answer. But if it is a more nuanced question, if they are using the term like early nodule, late nodule, then if it is early nodule, again voice rest. But if they use the word late nodule, then it is MLS, micro-laryngeal surgery. Micro-laryngeal surgery. Okay. Right. Now, let me show you few more things. Now, these are the two X-ray images you have to know only. Suhana, no. This is who is asking? The views. Now, these are the only two images about BPPV that you have to know. The first one is Dix-Hallpike maneuver. The second one is Appley's maneuver. Appley's maneuver is cyclical. Can you see? Appley's is shown in cycle. So, Appley's is always cyclical, second one. And Dix-Hallpike, only one or two images will shown. That's how you can differentiate between Dix-Hallpike and Appley's maneuver. Somebody was asking about this, I think. Yes, vocal cord nodule and polyp, we can give PPI. So, in vocal cord nodule, voice rest plus minus PPIs, that is correct. You can add PPIs because GERD is one of the regions of nodule. It is caused by vocal cord nodule. cool, cool nature. Yes. So guys, we come to the end of this session. We have discussed all the MCQs since 2018 till last year. If you still have anything to ask me, please ask me now. If you have any other question, please ask me. Otherwise, it was pleasure talking to you guys and discussing the past year's questions. And in the last moment, don't try to read anything new. I'll repeat what I told you in the beginning of the session, that you will not get the same question, but you know the topics that are important. The main reason why we discuss past year's questions is that you know the topics, especially if the question has been asked more than once, same topic, that becomes extremely important topic for you guys, isn't it? Revise them very, very nicely. Otherwise, if you have attended the lectures, then in the lectures, you have made your notes. If you don't have the class notes, you have not attended the lectures, get the short note, that one shot. One shot is the best thing that can happen in the last 1 month, 2 months. Revise last one shot multiple times. If you can revise the class notes, best. If not, one shot is extremely useful. Solve a lot of MCQs and that will take you through. Right. Now, yes, audiometry, please. What do you want to know in audiometry? So, like, there are few questions here. Suru, can you teach about nerve injury, recurrent laryngeal nerve? Nerve injuries, okay. One second, guys, hold on. I have deleted that slide. See, very quickly, I'll tell you a few things that you have asked me. One was nerve injury. See, 10th nerve is the only nerve in the larynx. 10th nerve supplies the larynx via superior laryngeal nerve and recurrent laryngeal nerve. Superior laryngeal nerve again divides into internal laryngeal nerve and external laryngeal nerve, and recurrent does not divide, so it remains recurrent. So, if there is a internal laryngeal nerve damage, aspiration is the only complaint. If they tell you aspiration is the only complaint, which nerve is damaged, internal is the correct answer. If only external is gone, low pitch voice. So if low pitch voice plus loose vocal cord are the only complaint, then external laryngeal nerve is damaged. If the patient has both the symptoms together, aspiration plus low pitch voice, then superior nerve is the correct answer. Superior nerve, right? And when it comes to the recurrent nerve, this depends, is it unilateral or bilateral? If it is unilateral damage, hoarseness is the only complaint, and it is bilateral, dyspnea is the main complaint. So if you remember this Suru, this is for Suru, then you can answer the question from vocal cord palsy. Based on the main symptoms, one of the 4 symptoms, you can pick the nerve. So this should not be difficult for you. Okay. So that is one thing. Then audiometry, I don't know, audiometry will take 1 hour to teach properly, but see, when you get an audiogram like this, let's say they show you an audiogram like this, right? Now there are 3 things you have to do when you get an audiogram like this, which is looking like this, but let's say you identify the 25 mark here and draw a line here, and just see if there is a graph below the line, below this 25 mark. If there is no graph below the 25 mark, there is no hearing loss. There is no hearing loss. If there is only AC is here, there is a graph AC, then this is conductive hearing loss. If only AC is below 25, then it is conductive hearing loss. That means BC is here. So BC is above, AC is below the 25 mark. This is conductive hearing loss. If the BC is also here, AC and BC both are below 25, then this is BC, this is AC. Now it is both AC and BC below 25. This is neither normal nor it is conductive hearing loss. This is either SNHL or mixed loss. So both in SNHL and mixed loss, AC and BC comes below 25. So the last step is, when it is both below 25, like in this case, how do you know it is SNHL or mixed loss? So then you look at AB gap, the distance between the two. If the AB gap is less than 15, then it is SNHL. If the AB gap is more than 15, then it is mixed loss. That means if they are very close to each other like this one, then the gap is less, it is SNHL. This is your SNHL, because the gap is less. But if one is here, AC, now the gap is more, then it is mixed loss. So if both are below 25, lot of gap, it is mixed. If the gap is not there, it is SNHL. If only AC is below 25, it is CHL. If there is no graph below 25, it is normal hearing. This is the minimum that you can remember. So if you look at these 4 graphs, see, this is 25. There is nothing below 25. This is normal. This is normal. Now this is 25. AC is below 25, BC is above. This is CHL. This is how CHL looks like. One is below, one is above. Here both are below 25 and they are close to each other. This is SNHL. And this one, where both are below 25 but the gap is more, this is mixed loss. So graph can be one of the 4. Audiogram can only be one of the 4. First one is normal, second one is CHL, below first one is SNHL, last one is mixed loss. In this much time, this is the only thing I can tell you, Suhana Purohit. Now, I cannot show you all the instruments here, Bibhu, but try to identify otoscope, some of the nasal speculums, ear speculums, tonsil instruments which I show in the classes. Whatever instrument I have shown in the class, those lecture, those are the instruments that you need to remember, right? A croup can cause either expiratory stridor or biphagy. Both the stridors are possible in croup. Zomo Medico, this is for you. Croup can have both the stridors, expiratory and biphasic. Nerve I explained. A patient is hearing his own footsteps. क्या बात कर रहे हो यार दिव्या बिराज? Don't you hear your own footsteps? When you walk, you can't you hear your footsteps? Everybody normally hears the footstep. ये क्या बात हुई? You are talking about autophony, I know, but footstep नहीं है, breathing sound से होता हो. That is autophony. Autophony, where the patient starts hearing his own breathing sound. It is not about footsteps. Okay. And this happens in two conditions. It happens in minor syndrome and patulous station tube. These are the two conditions which causes autophony. Autophony is a situation where the patient starts hearing his own breathing sound, not foot plate. Okay. So options were superior canal. Minor syndrome is other name for SSCCDS. So SSCCDS is the correct answer in that case. So Divya Raj, that is SSCCDS. Your answer is SSCCDS. In audiometry, if we see a dip at 2000 like this, then this is Cahart's notch. This is seen in autosclerosis. If you see upward sloping like this in AC and BC, upward sloping, this is Meniere's disease. Meniere's disease. Okay. Audiometry below 25 mark means the threshold is more than 25 decibel. Because in audiometry, if you look at the audiometry, it is going the reverse. This is 0, this is 10, this is 60, this is 100, ulta chal raha hai. So below 25 means more than 25. So the below 25 mark, this is a mark. So when I say below 25, I mean the mark is 25. Below that, that means the threshold is more than 25. This is diagnostic of hearing loss. If the mark is below 25, the threshold is more than 25. So expected stridor is more in croup. Subject क्या चीज है? नजीर शेख, subjective objective ये क्या है? Downward sloping audiogram is seen in 4 conditions. Downward sloping audiogram can be seen in presbyacusis, noise-induced hearing loss, noise-induced hearing loss, ototoxicity, and acoustic neuroma. 4 conditions that can give you downward sloping. यार ये नजीर से ये सब्जेक्टिव ऑब्जेक्टिव क्या है? दोबारा से पूछो यार. What is subjective objective? What is it about? Are you talking about tinnitus? Because subjective objective is only used for tinnitus in ENT, but don't waste your time in that. If it is tinnitus, my advice is don't waste your time, forget it. वो कभी नहीं आएगा एग्जाम में, उसको भूल जाओ. So that should be it. I have answered all your questions. Criteria for surgery of DNS. Suru. DNS needs no surgery. DNS no surgery. If any symptom that bothers patient, then septoplasty. This is the rule. For DNS, we don't do surgery. If DNS is causing any symptom, there is no, you can't say blockade hai to karenge ki anosmia hai to karenge. If the patient says I have a problem, if this patient says I have a blockade, nasal blockade due to DNS, and you say it is bothering you, he says no, I know there is a blockade, but it is okay, then no surgery. If the patient says yes, I have problem, my lifestyle is disturbed, then you do septoplasty. So for DNS there is no surgery, but if there is a symptom that bothers the patient, that is a criteria, then you do septoplasty surgery. Suru, this is for you. So I think I've answered all your queries. Subjective and objective test for hearing. Subjective and objective test for hearing. See, these are the 4 tests for hearing. First 2 are subjective, and these 3 are objective. This is for you, Bivu Arya. Bivu Arya, this is a complete list. So I think this answers your question, Bivu Arya. No, the main blood supply of the tonsil is tonsillar branch of facial artery. The main blood supply of the tonsil is tonsillar branch of facial artery. It is not ascending pharyngeal artery. So these are the subjective to objective. Bibu Ari, I hope you have got the answer. But we cannot discuss the test for hearing because it's a very long topic. जितना time हमने किया discuss, उससे ज़्यादा time तो it will take if I discuss. So Bivu Arya, you write down my number. Okay, write down my number and you send me the question that you want me to solve. If there are any questions that you personally have tried to solve in an MCQ book, if you have any question you want to solve, you send that question on this and I will answer. I will discuss with you personally. Okay. If you have any questions, so guys, you can take down this number. You can contact me on WhatsApp. Don't post me on Telegram. I don't watch Telegram. On WhatsApp, you have to post your question, your query on this number, and I will be able to answer the question there. And one request to you, after the exam, please share the ENT question on this number so that I can discuss those questions the same day of the exam. 23rd ko evening me I will try to solve the questions and discuss the answers, but please give me the answers on this. It's a humble request to you guys. I will want these answers, questions, proper questions with correct answers. Everybody bhej dena. Okay, so thank you guys, lovely teaching you always, and I really hope that you do the best, you get a good rank and get the subject of the choice in the college of your choice. Till then, take care, keep working very hard. God bless you guys. Bye for now.